Now, on to our main plenary session. Our first moderator will be facilitating the first and the fourth sessions of this conference day. He took his Doctor of Medicine at Gulyas College of Medicine of the University of Visayas in Cebu. He spent his internal medicine residency at Zamboanga City Medical Center and took his fellowship in medical oncology at the University of Philippines Philippine General Hospital. He is a diplomate and fellow of the Philippine College of Physicians and the Philippine Society of Medical Oncology, a fellow of the Philippine Society of Oncology, and a member of the European Society of Medical Oncology. He is part of the faculty of Ateneo de Zamboanga University School of Medicine and the training officer of the Department of Internal Medicine, Zamboanga City Medical Center. Ladies and gentlemen, we have Dr. Nelson Laja.
Assalamualaikum warahmatullahi ta'ala wabarakatuhu. Thank you, Dr. Jabbar Isturco, for the kind introduction. Once again, I am Dr. Nelson Laja, a practicing medical oncologist, and I am your moderator for this plenary entitled The Medicine and Islam of End-of-Life Medical Care. Please join me in two separate sessions with a joint open forum later. And now for the talk on the DNR decision and on the Islamic perspective of end-of-life care and clinical death, which will come after the plenary on family planning. So in the name of Allah, the most gracious, the most merciful, praise be to Allah, and prayers and peace be upon the messenger of Allah. In almost every kind of care, be it a terminally ill with a poor prognosis metastatic lung malignancy, or maybe a critically ill patient with a complicated massive myocardial infarction, are those considered to have such poor prognosis that they would not survive cardiopulmonary resuscitation for cardiac arrest, or would survive with poor function and poor quality of life. And do not resuscitate, or shall we say a DNR order, can then be made by the responsible physician. That is neither basic or advanced CPR would be performed. If the patient does not have any DNR order, CPR must start anytime once necessary. A DNR order is definitely a shared and collaborative decision on the part of the family of the patient with their healthcare providers after everything has been discussed, especially on the aspect of prognosis and survival of the disease, and maybe by the patient in a situation where such event has been discussed ahead for a certain terminal medical condition like metastatic cancer as part of the advanced directive plans. As Muslim medical practitioners, which we all know, everyone here in the Zoom, we are all medical professionals. We always believe in the principle called Al-Qadar, which is the concept that Allah knows everything and has already decided everything that will happen. As the famous saying goes, it is the duty of us doctor to prolong life, and it is not our duty to prolong the act of dying. So to shed light on this topic on DNR decision, it is my honor and utmost privilege to introduce to you our first speaker to share us their best practices and policies on this subject matter. So he is a consultant of the palliative care and pain medicine in the King Fahd Medical City, Riyadh, Saudi Arabia, a program director of Palliative Fellowship Program, a founder of the palliative care at the King Fahd Medical City, a Saudi and Arab Board of Family Medicine, a palliative care fellowship. He had palliative care fellowship in University of Toronto, Canada, and had his medical education fellowship at the University of Toronto, the same country. So, ladies and gentlemen, please help me welcome to the virtual stage Dr. Muhammad Faisal Abusuda. Doctor, Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. I'd like to thank you for your nice introduction. I hope that my topic will be of interest and benefit to everybody. And I'd like to thank the organizer for inviting me for this very interesting conference. I haven't been into Philippines in my entire life, but I wish one day I will visit Philippines. And I've heard very nice things about Philippines and the nature of the country and nice people, good manner, and I hope one day I will visit Philippines physically, inshallah.
Inshallah, Doctor. We are very much welcome to come.
Yes, thank you so much. I'm Dr. Muhammad Abu Sauda. I started my career in family medicine, then I specialized in palliative care, and I founded the palliative care in King Fahd Medical City, which is one of the biggest health institution in Saudi Arabia, related to Ministry of Health in Saudi Arabia. I'm gonna talk about DNR and DNR order. This I usually give this this is as a course, maybe 3 hours, but I will try to make it summarized. So I'll talk about some important definitions. Who should decide, physician versus patient, DNR policy in Kingdom of Saudi Arabia, and DNR in Saudi Arabia in general, and discussing DNR and Spike's approach. Probably the topics are a little bit long. If the time finished without completing my slides, it's okay. Actually, the most important point is to get benefit from whatever we learned from this lecture, and it's not very important to finish everything. Because still we have time, we can read, we can find ourselves, but at least to give some hints about this topic. And it's very sensitive, very crucial, and it has lots of things within it. It has medical part, ethical part, religious part, cultural part, and also skills how to deliver this news. And I would start with the shocking sentence just to grab your attention. All people are naturally under state of DNR. I think everybody is DNR, except those few thousand who attended to the hospital and rescuer. They are labeled as full code. So if somebody, his heart stopped in the street and nobody is from the medical field, or people who cannot do CPR, then he's DNR, then he will die naturally. So what I mean by DNR is natural death. So I think all of us will go through this, except those who had the privilege to have CPR done. And one day I decided that if my heart stopped, I would like to die naturally. I want to die without CPR. And when I say again DNR, I mean allow natural death. What about you? What do you think? Have you thought about this in your own? Now we will move to the definitions. Cardiopulmonary resuscitation, it is an emergency procedure that combines chest compression, often with artificial ventilation, in an effort to manually preserve intact brain function until further measures are taken to restore spontaneous blood circulation and breathing in a person who's cardiac and pulmonary arrest. Somebody, his heart stopped. You want to move his heart from outside by compressing the chest to allow the blood circulation to go to his brain and to the vital organs, hoping that the heart will start spontaneously using DC shocks and some medication. Do not resuscitate, it stands for do not resuscitate DNR, which refer to that in event of cardiac and pulmonary deterioration or arrest, cardiopulmonary resuscitation measures will not be initiated. The order is that the medical order that prohibit a specific cardiopulmonary intervention in the event of cardiopulmonary arrest. This order provides mechanism for clinician to guarantee the care will be consistent with patient advance directive. And advanced directive means that the major goals of the patient, so if the patient will receive curative treatment, or he's only for comfort care, or he would like to be treated at home, these are the main ideas. So the major goals, not the specific, the daily activity goals. So here, according to advanced directive and other supportive measure, example, or i.e. Basic care to maintain the patient comfort shall continue. Who is the DNR patient? Those patients who's suffering from irreversible terminal illness, which are under constant view to be in dying process when recovery it's deemed by current scientific evidence to be impossible. So here is some patient or some kind of diseases that DNR is appropriate for them, like advanced late stage cancer, irreversible multi-organ failure, advanced chronic liver disease, advanced congestive heart failure, advanced pulmonary disease, advanced dementia, severe brain damage, inoperable malformation that are incompatible with life, fetal chromosomal anomalies, fetal neuromuscular disease, severe multiple trauma, diagnosed brain stem death, failure to respond to critical care support. Here is also some confusing definitions or terms. Most of the people, they get confused with these three terms: withdrawing, withdrawal, withholding, withdrawing, and limited escalation. Withdrawing, it refers to stopping cardiopulmonary resuscitative measure or life support measures. So the withdrawing, the measures are going on and you are going to stop these measures. Withdrawal of critical care support, it is to stop it is to stop cardiopulmonary hemodynamic biomechanical dialysis support and stop hemodynamics biochemical and blood count monitoring. Withholding is refraining from starting cardiopulmonary resuscitative measure. So this patient he was not started any cardiopulmonary resuscitative measures, and you're not going to start these measures. Limited escalation refers to clinical guidance setting out limits. So suppose that the patient is admitted to ICU and he is on inotropes at certain dose. So if their blood pressure goes down, you're not going to increase this medication. You're going to limit the escalation of cardiopulmonary resuscitative measures. As I said, if he is in a cardiogenic shock and he's on inotropes and his blood pressure start to go down, you're not going to increase the inotropes. And if the patient is on respiratory ventilator, you're not going to increase the oxygen and the effort of the machine in order to improve oxygen saturation. So this is limited escalation. Now we will move to the second important point. Who should decide? Is it a patient decision or a physician decision? One core debate surrounding DNR order is the question of who ought to have authority to put such order in place when patient is in a hospital. Is it patient or physician? Some argue that patient should be the one who choose to be DNR. Each patient has the right to decide whether he or she wants their healthcare team to try to resuscitate him or not. These are personal choices that involves trade-offs between the possibility of living longer and the goal of having a peaceful death. Only the patient is in position to determine which of these things is more valuable for him. So in some cases, patients are unable to make those decisions for themselves due to chronic condition, then the power of attorney will decide for them. So this is one argument. The other argument, argument is physician directed. So in this case, there is a strong ethical case to be made in support of the position that the medical team, usually the attending physician, should make that decision, whether to put a DNR order in place for particular patient. The physician has training, has experience, has knowledge, and he is the best to make these kind of these decision. Also, the physician judgment is not based on emotions like patient. The patient would like to live longer. He doesn't know the medical practice. He just wanted to live longer, but the physician will base his decision on his experience, his knowledge, and his own scientific basis. It is the role of medical professionals to determine which intervention are appropriate given the situation at hand. As a result, some argue they are in the best position to decide whether attempting resuscitation is likely to help someone or do more harm than good. So this is one argument. Of course, it should be combined decision. So the physician will give the advice to his patient, and the patient likely to accept the clinical judgment with good explanation from physician. But what if the physician and the patient disagree? What will happen? What would be the situation? So in this case, I think when patient autonomy and clinician professional obligation conflict, which argument is stronger, who should decide? For example, in the Western country where I trained in Canada, the patient is the one to decide. In Saudi Arabia, it is the physician who should decide, because it's more likely a medical decision. When a physician is in a position to stop chemotherapy, for example, for a patient because it is not beneficial. DNR also is a medical decision like any other medical decision. If this procedure is not going to be helpful, why should we do it? So each country must agree on who should decide the DNR based on religious, cultural, ethical values. So I'm not supporting this side or that side. It's very important that each country has this in mind and they base their decision based on their own cultural and ethical values and also religious values. So in that case, since we country has to agree, we need to also have policy to be very clear and unify the practice. So in Saudi Arabia, task force prepared national policy and procedure for do not resuscitate when heart stop in 2017. So it is very recent. But this is very important accomplishment that we have a national policy now about DNR. So every patient should receive cardiopulmonary resuscitation unless it is documented that this patient is in DNR. The DNR order is appropriately recommended when the patient is terminally ill and when resuscitation measure in the best judgment of the attending consultant would be ineffective at saving the patient life. So for those patients who are already admitted to critical care or who have no response to aggressive life support intervention, or who are assigned a DNR order, the attending consultant should consider the following three options: either withholding or withdrawing or de-escalation. I made this because it's a very dry area of discussion. It's policy, and I'm presenting these policies just to show you that experience. It does not. You don't have to agree with this policy. Myself, probably, I don't agree with some of them, but it is a good policy. It is made by multidisciplinary team, including sheikh and ethical committee, and also expert in the medical field, physicians, and so on. So I made it as questions and answers. So a non-Muslim patient with locally advanced lung cancer is on active treatment for curative intent. Despite that, he requested that the consultant to sign a DNR order. So he wanted to be a DNR. What would be the best action that might be taken by the consultant? Should he sign the DNR or not? I'm not gonna read these the questions, but I just want you to think with me. What could be the action of that physician? Should he sign the DNR? What he should do? And the answer is C. The consultant should not sign the DNR, and he must clarify to the patient that this action is against Sharia law. And why is that? Probably this is suitable in Saudi Arabia, but probably it is not suitable in any other country, because in the policy of Saudi Arabia, all hospitals recognize the responsibility to provide acceptable care whilst safeguarding the cultural, psychosocial, religious value of each patient in accordance with Sharia law. So adding Sharia law, we should follow Sharia law in our practice. The primary interest of the hospital is to sustain life while respecting patient wishes regarding dignity, respect, and comfort in dying process. But this patient is his disease is not advanced, and he might get cured from his disease, and he's probably more emotional to decide for himself not to be resuscitated. Some ethical consideration: DNR order shall only shall be no means compromise the healthcare provided to the patient. So everything should continue the same as long as the patient is tolerating any procedure, and he should be feeling comfortable. So most of the time, people, when they hear that this patient is DNR, they will provide less care, which is not appropriate. So even if he is going for surgery, physicians should not stop the surgery because of that, unless the patient, because he's DNR, we can have the right to decide not to do the surgery because the patient cannot tolerate. But if the patient could tolerate procedure or surgery, then we should go for that despite DNR. A patient with metastatic pancreatic cancer and is not fit for further chemotherapy, who should sign the DNR? And the answer, it's just because of time, I'm gonna put the answer is the attending consultant and other two doctors are not less than specialists. So 3 physicians, expert physician, one of them is a consultant, and 2 are not less than specialists should sign the DNR. And this is included in the policy. So the attending consultant is the one who is responsible about the patient at the time of the clinical area. So it's not the primary physician who probably doesn't know the patient. So the most physician who know the patient best is the one to decide for this patient whether he should be DNR or not. The 3 physicians must be well informed about the patient condition in order to make a decision on the DNR status of the patient, and they should all sign the medical record in the patient. Physician decided to sign the DNR order, and the attending didn't inform the patient or the family yet. What should the attending do? Should he inform the patient? Should he inform the family? Or it's okay not to tell the patient? In this case, it is up to the attending consultant judgment of appropriateness to inform or not to inform the patient family about DNR. So if the physician judgment that informing the patient or the family will do more psychological suffering, then he has the right not to tell them. And this is actually according to Saudi policy, but not necessarily to be right, actually. Myself, I disagree with that because I'm handling those DNR patients every day, and not informing them definitely will make them asking so much question, making trouble, complaining because you did not do the DNR, and they think that you're ignoring their patients. So I think this policy should be changed, but however, this is what it is written, and we should follow that policy. But the policy did not. The policy give you the right not to tell the patient. But myself, I usually give the information to the patient. The attending physician decided to sign the DNR order, but he was not available in the hospital. Who should sign the DNR? And this could happen actually. They call you while you are at the mid of the night. Well, this patient is in a bad condition. We need to sign DNR, and you know the patient, and you agree that the patient should be in DNR, but you're not available in the hospital. So what should you do? Should you ask your colleague from ICU or from emergency room to sign the DNR? And this might happen sometime in certain situation, but the answer is D. The physician may give the order by phone to his designee, and attending must sign within 24 hours. You should not ask your friend from ICU or from other department to sign the DNR, because they don't know the patient as you know the patient. This I have explained the answer. We'll go to the next question. A patient so in case of telephone order, it is allowed according to the policy. It is allowed. It should be next day within 24 hours. Should be signed by the consultant. A patient had a DNR order documented in his chart. 9 months ago, he came to the clinic for follow-up. The nurse asked the attending consultant if DNR was still valid. And this question is asking about the validity of DNR. Again, in the policy, it should be very clear how much time when the DNR should be valid, or for how long the DNR should be valid in the clinic or in as inpatient. And the answer for this question is B. Attending must reassure the patient that the DNR order is still valid and no need to renew it because it does not pass 1 year. So the DNR order must be reviewed, updated, clearly documented periodically, at most every 6 months for inpatient, reflecting changes in the patient file, but for outpatient, it extend to up to 1 year. So the policymaker should make this very clear when to update and review the DNR order. A patient with DNR order is documented in his medical record. He will be transferred to another hospital. What should be done regarding the DNR order? So again, the policy should address how you are going to transfer DNR patient from one institution to another institution. And it should be very clear. Again, whether you agree with this or you disagree, you have to make your own policy, and everybody should be clear about this. The DNR order is considered valid for 24 hours during and after receiving the patient, and a copy must accompany the patient. Then the other institution will make their judgment, and they will decide whether to continue DNR or not. And this will explain, has been explained in the question. There was a conflict between the attending and other physician about the appropriateness of the DNR order. So if there is two consultants at the same level, both they know the patient, and one he said that this patient should be DNR, the other one said no, this should not be DNR. If this case, what should we do? How can we make the decision? And here's the options, but the right one: the chairperson or medical director shall resolve the conflict following the existing procedures. So there should be a third person, and that third person should be of a higher authority or higher experience. When there is a disagreement or conflict regarding the DNR decision between the attending consultant and other physician, a departmental chairperson or medical director shall be consulted in accordance with existing policy and procedure to resolve such conflict. A patient with written DNR order and is going for surgery, what should we do for this patient? He's going for surgery. Should he continue the DNR, or the DNR should be reversed? And in our policy, the answer is D. The DNR order is automatically reversed during surgery and automatically reactivated 48 hours after the surgical procedure. So this is, again, should be very clear, and you should make your own policy in that regard to make it clear, and everybody will follow the same. A female patient has a written DNR order and she has viable pregnancy. What would be the best action? So what would you do if you have a pregnant lady and she is DNR? And the answer here is C. Okay. The answer is C. The DNR order shall be on hold until an emergency cesarean section is appropriately performed to save the baby. A patient with written DNR order for more than 6 months and his condition is improving. What would be the decision about DNR in this case? And the answer is A. The attending may revise the DNR order and must document the reversal of the DNR order in patient with medical record. Not all our patients that we decide that they are DNR today, maybe after 6 months they will improve, and then we have to reverse. It's not a Quran. It's not the final decision. We should review the DNR order frequently for certain period, and you should make that decision in your policy, whether it's 3 months, whether it's 6 months, and if the patient improved, then you have to change the DNR order. Okay. A patient with a written DNR order and was transferred to another consultant. The receiving consultant believed that DNR is against his value and religion. Of course, you will find somebody who, in his own belief, that DNR should not be done, should not be ordered. Everybody has the right to do CPR. What would be the best action if that physician is receiving the patient? In this case, the patient may be transferred to another consultant who will honor the order after consultation with the departmental chairperson or medical director. So the role of the medical director is to make sure that the decision of DNR is right, and also to assign this patient to a different physician. Because if you as a physician don't believe in DNR, yeah, that's right, that's your right, you should not take care of DNR patients. Okay, it's just because of time. I'm gonna be in a hurry, and also the Saudi policy is based on fatwa اللجنة الدائمة للبحوث العلمية والإفتاء, and it has a number, and these are the conditions that DNR should be signed. Like, for example, if the patient arrived to the hospital already dead, or a patient who's having 3 physicians decided that this patient is not suitable for resuscitation, If there is a terminal disease that is not responding to treatment, and a patient who's having decreased, severe brain injury that is probably not improving, and or brain death, and so on. Then we will move to the conclusion of what I have mentioned. Each country must develop a multidisciplinary DNR policy and guidelines to streamline the practice. And this is very important. And the whole point of stating all these policies is not to follow the Saudi policy, and not also for everybody to agree on it, but in the practice, it has to be clear, it has to be made by multidisciplinary team, and it has to be followed. So there will be no confusion in the practice. So let's talk about the story in Saudi Arabia. The concept of do not resuscitate in Western countries was introduced at the beginning of 1970s. Actually, 1970s, it's about 50 years ago, when maybe I was just 1 year old or so. In Saudi Arabia, in 1995, many hospitals in Saudi Arabia do not have the DNR policy, and they employed physicians from different backgrounds, from Arab, from non-Arab, from Asia, from Africa, from Europe, from America, and everybody has different belief about DNR. A questionnaire, and I'm not sure how much time left. A questionnaire was completed by 100 physicians in internal medicine and critical care in 2 public hospitals in Riyadh. About 71 thought that the patient did not have the right to refuse treatment. Okay, 10 minutes. The majority felt that DNR is a physician decision. A survey was conducted in a tertiary care center in Riyadh. About 96% were aware about the existence of DNR policy in their institution. Also, 95% stated that DNR is not against Islamic regulation. The 2 most common barriers to DNR decision were lack of patient and family understanding and inadequate physician training. The main obstacle in initiating a DNR order were patient and family level of education and cultural factor. So these are the main barriers from the side of physicians and from the side of the patients. A self-administered questionnaire was provided to patient to elicit a response regarding knowledge, perception, and attitude toward DNR from a patient. Most of the participants refused to be on a DNR order if they were diagnosed with terminal illness. This is probably a high number. Most participants wanted to be involved in decision making. About 87% of patient participants would like to learn more about DNR order, and the knowledge score regarding DNR was found to be significantly associated with higher acceptance. So if you explain to the patient very well, or to the family, what is DNR and the indication of DNR very clearly, then the family would accept DNR, not the opposite. The study conducted in a teaching hospital to assess compliance of physician with the current DNR policy. Patient chart were followed prospectively to observe DNR documentation completion. There was a delay for more than 48 hours in completing the signature for 8 patients. So there is a documentation, no signature at all in the 20%. Documentation of discussion with the family was absent in 53%. So it's very important to do this documentation. It's a medical legal report, so you should document. There was significant reduction in the vital signs documentation, test completed, documentation, and visit by physician after DNR order. So this is another quality measure that we should pay attention to. Signing DNR does not mean neglecting the patient. It's very important. Okay, it's just because the medical record of 240 in-hospital cancer deaths were reviewed to explore relationship between palliative care timing and the frequency and timing of do not resuscitate decision or designation. About 80% in those were never were referred. So we'll see here that the mean, if we can see here, the group of patient either early referral, so more than 90, or intermediate between 30 and 90 days, or late, less than 30 days, and no palliative care. So if the DNR order was made or early, and the referral to palliative care was early, so the median DNR to death time was 96 days if there is early referral to palliative care. Late referral to palliative care would mean that the patient will be more likely to be admitted to ICU, and the care provided to the patient is probably less. KSA is an example of Muslim country that has successful journey in developing DNR policy. It needs further development, and it could be replicated in many other countries. So if we have a policy and procedure in Saudi Arabia, yes, we can. Other countries who don't have policy and procedure, they might use the Saudi policy and modify it a little bit according to their culture and belief and values. There was a video that I wanted to show you, but probably I don't have time to show this video, so no need to add the video. It's about discussing DNR, which is a skill. And I think it is very important skill, how to discuss DNR. And I think this also in my workshop, we do role plays and many other things to make it more practical. Immediate survival is the success of CPR is about 15%. To discharge. For cancer patient, as an example, it's about 0% to discharge from hospital. They might be admitted to ICU for some time, then the patient will die. So most of the patient, they will have no success of DNR, and that's why we decide not to do DNR. Some people think that because it is aggressive and it causes breaking of the ribs and inserting a tube in the patient, and that's why we don't want to do it. No, the reason for do not resuscitate order is because CPR is not useful, and it is not successful, and it will humiliate the dignity of our patients. The factor that increase survival with the CPR, if the patient have coronary artery disease, drug overdose, location of arrest in ICU. Factor that decrease the survival, including sepsis, cancer, bedbound patient, acute renal failure, and dementia. What are the difference between these two questions? I want you to read these two questions. When you discuss your patient, discuss DNR with your patient or with your family. If somebody is asking you, if you get an infection, would you like me to treat it with antibiotic? The answer would be yes. If your heart stops, do you want us to do CPR to bring you back? I think most of the patient would say yes, is how you put the question. There is no difference from the patient perspectives between the first question and second question. So these questions are leading question to answer, yes, I want CPR to be done. So there's no difference between these two questions. So when we talk to our patient, we have to be very clear. We have to make sure that the patient understand what we are saying. Would you want us to do everything? How about this question? Do you think, what is everything? The patient will not understand what you mean by everything. Everything is a very vague. Yes, I want you to do everything. There are some recommended steps during discussion. 6 steps, like establishing the appropriate setting or asking the patient and family about their understanding, finding out what they expect will happen, discuss the DNR order, including context, respond to their emotion, establish, implement the plan. These are different approaches. They are almost all the same. You can find it in the literature. This is also the DNR four keys of effective patient communication. Again, you can find it in the internet. It initiates support discussing with the patient, clarify the patient question regarding prognosis, identify and document end-of-life goals, discuss, facilitate the treatment plan. And actually these, you can read it and understand it, but most of these are coming from different culture. The American culture is different from European, and the Asian, and also the Saudi culture is completely different from Filipino culture, for example. That stop. Should I stop? Just few more comments,
Okay.
because just very small comments. Actually, the problem with this approach, they are very good. It's very important to use them, but the problem is how to say the word, how to use the phrases. So each country should use should do more research how the family would like to hear and to discuss these sensitive issue. There are some phrases are suggested by the Western literature, probably not appropriate to our culture. So during our discussion to DNR, we have to use the phrases that is sensitive to our culture. These are description of spikes. As I said, phrases during discussing DNR must be chosen carefully and be based on research and not only based on expert opinion. Thank you.
Okay, thank you, Dr. Muhammad. I feel the enthusiasm and excitement from you as you want to share everything in your slides. However, due to time constraints, we need to to fast track our lecture. But rest assured, no, as what you have shared to us, we felt like it's like me as a practicing medical oncologist here in the Philippines. I appreciate everything the policies of the KSA of the Kingdom of Saudi Arabia in terms of how to handle, how to furnish a policy or an order or a waiver for a DNR. Okay, I guess our audience in the Zoom are very much excited to post some questions. But however, we will be having our open forum after the lecture of Dr. Tariq, which will follow after the lecture on family planning. So for now, I would like to thank Dr. Muhammad, and please join us later for our open forum. Is it okay, Doctor?
Actually, I have a clinic after a few minutes, and
Okay.
probably I will be in the clinic. I will try my best to rejoin again. If I couldn't, then I apologize. But I will try my best. Sure.
Okay, sure. Or maybe perhaps we are really want to get your insight. Maybe we can ask for an email so that we can just email you for our inquiries if
You have
you're
here my Twitter, and also you can put my email. Welcome to all questions. Thank you. But I
okay.
will try
Thank
my
you.
best to be available. But what time? Just let me know. What time will
Okay.
be the forum, uh, the discussion?
After 1 to 2 hours, perhaps
1 hour?
1 to 2
Okay.
hours, perhaps. Yeah.
Okay. Okay. Okay.
Okay.
Sure.
So
Thank
thank you, Dr. Muhammad. We hope that you can visit us here. And as a medical oncologist, I'm so interested to meet you because our partners in the care of our patient is really a palliative care specialist, especially those in the metastatic state. So thank you very
Yeah,
much and hope to see you
I
later.
will be honored to visit you and to also to share if you want me to come for like a locum or whatever you think is appropriate. I'm very happy to join you and also to work with you and see if there is anything that need to be done about palliative care in cancer patient. Thank you.
Or maybe perhaps we will visit you there and we can see each
Yeah,
other.
most welcome, most welcome.
Okay. So thank you, Alhamdulillah, for these sessions. And so for everybody in the Zoom, let's take a break for a Maghrib prayer, and we'll be coming back after 15 minutes. So for now, thank you very much, and wassalam.